Okay, we're going to be recording for week 1, and I'm going to share my screen. We're going to be covering chapters 1, 2, and 3 tonight, talking about family culture and health promotion and assessment. Some of the things that we're going to talk about tonight include not just labor and delivery, but going back as far as preconception, several weeks prior to pregnancy and 6 weeks postpartum, post-delivery period. Preconception, some of the things that we think about or we want to talk about with our clients. Preconception include things like planning for pregnancy, important to take maybe prenatal vitamins, especially folic acid, if we're planning for a pregnancy because of neural tube defects. Neural tube defects including things like anencephaly and spina bifida. We know that folic acid is very important in preventing those conditions, and if we're waiting until our first prenatal visit before we talk to clients about the importance of folic acid, we've missed that window of opportunity to prevent those developmental anomalies because they develop neural tube anomalies develop very early in pregnancy. So we want to start clients on folic acid and prenatal vitamins prior to conception, so we prevent those types of issues. So our care ideally starts preconception. Issues and trends in nursing, we talk about limited access to care, and there's several things that are included in why patients don't receive appropriate nursing care during pregnancy. Some of it is financial. Some of it is that they can't afford the visits or don't have insurance to cover the visits. Sometimes they don't have transportation to office appointments. And there are several throughout pregnancy. So whether it's financial or a lack of coverage for care, or they have a couple children under school age and they're dragging those children to office appointments, and it's just very stressful to be pregnant and keeping up with 2 toddlers in a office waiting on your prenatal visit, and they just choose not to come. So there are lots of different factors that may prevent people from coming in for appropriate nursing care. Check in your text and look at the tables that talk about some other issues that and trends that are affecting current care for during pregnancy. Healthy People 2020 and Healthy People 2030 will give you a lot of insight into pregnancy care. SBAR. SBAR is something that we use to assure appropriate communication between clinicians and patients. SBAR stands for Situation, Background, Assessment, and Recommendation. You're going to see Table 1.1 in Chapter 1. We'll talk more about SBAR and its importance. Every facility that you work in is going to address SBAR at some point during your orientation and probably annually in competency. Failure to communicate results in medical errors, and medical errors are the 3rd leading cause of death in the United States. So whatever we can do to prevent errors in the healthcare setting needs to be done. So we are addressing SBAR in orientation when we hire new healthcare providers, nursing staff, um, AIDS, STNAs, um, all aspects. Housekeeping is involved in nutrition services that are involved in SBAR. Everyone that is hired in a facility goes through SBAR training because we all have to work together to prevent any kind of medical errors. So it's everybody in a facility that needs to um, be aware of what SBAR is. And the bulk of it um, is physicians and nursing staff, but everyone in the facility is aware of what an SBAR stands for. Standard of practice. When we talk about standard of practice and the legality of it, standard of care is the level of practice that a reasonably prudent nurse would provide in a similar circumstance. And this is important if you would ever be deposed or be called in to testify in any kind of legal action that would take place. They're going to judge or hold you accountable to what a reasonably prudent nurse would have done in a similar situation. So, number one, you need to know what competent practice would be in a similar circumstance. Negligence is if you fail to provide that competency of care or that standard of care. And one of the ways that you assure that you're providing that level of care to your patients is being sure that you know your facility's policies and procedures. So if you don't know what to do in any given situation, don't rely on your peers. Don't ask a nurse that you think, oh, they probably know. Go back and pull up your policies. Now with um, computers being so available to all of us, all of our standards are right there at our fingertips. So if you're questioning how a procedure should be done or what a facility policy is on anything, pull it up. Don't ask somebody sitting next to you. Pull up the policy, pull up how the procedure is done, and practice according to your facility policies in order to be sure that you are practicing according to the standard of care, because that's what you're going to be judged on. Okay, when we're talking about family, we care for patients and family in all aspects of nursing across the life span, but especially in maternity, we are caring for the entire family group, and that may include a nuclear family that has married parents. It may be blended families from including parents who are divorced and bringing step parents into the scenario. It may be extended families that are included in that group. We have multi-generational families that live together that make up the family unit. We have non-biological parents that are caring for children. We have cohabitating parents. We have single parents. We have LGBT parents. We have alternative lifestyle families raising children. Um, a family is whatever that person sees their family unit being. And we want to be very careful that we are not judgmental as far as what our vision of a family unit is, because that family unit is whatever they see it as being. When we are in med surg, when we talk about pain, and a person's pain is whatever they interpret it to be. In this situation, a family unit is whatever our client interprets it to be. I had a patient once that the mother that was delivering or had she had just when I took over care on her, she had just delivered, and her husband was in the room, and he was the father of the toddler that was running around the room, the father of the baby that she had just delivered, um, was in the room, and they all lived together, um, as a family unit. Um, Her husband was holding the newborn, sitting in the recliner, and the father of the newborn was chasing the toddler around the room. So it was a very different dynamic than what we usually see, but it was a family unit that worked for them. They all seemed to be very happy with this newborn, very attentive to the other toddler running around the room, and it all worked for them. Um, so who are we to judge what makes a family unit? And um, the dynamics worked just fine for this family. Um, Culture. When we are talking about culture in relation to childbirth, we see a lot of different ways to give birth, ways to raise a child, um, thoughts about laboring in itself. And some of them are influenced by religion, by environment. Historical factors play in. Um, there's a lot of different things that attribute to um, how those cultural aspects affect labor and delivery. And when we're talking about those things, there's three terms that come to mind. Cultural competence is just the knowledge of different cultures and being aware of um, how they impact our clients and how they want labor processes to go. So being culturally sensitive to things that impact our clients. Um, and if you live in an area that has a high population of certain um, cultural groups, you're going to be much more culturally competent with those groups than most. Um, my daughter lives in Arizona, and she would be much more competent caring for, say, Hispanic populations of patients than I would living in Kentucky. Um, so if you have a patient who is of a different ethnicity than you, you may need to do some research or ask them, um, are there things that you um, want to be included in your labor process or your birth process or your birth plan that I can help implement for you. And it doesn't hurt to ask if it's a culture that you're unfamiliar with. Um, just be transparent with them. I'm here to make your birth process what you want it to be. Um, Help me to do that. Ethnocentrism is when you think your cultural um, biases, I guess, is right and appropriate, and you project that onto others as being the way or the correct way. Um, and we know that our way is not always the best way or the only way, but that way of thinking is ethnocentrism, that the best way is our way and it revolves around us. Um, Cultural relativism is being cognizant or aware that um, there are many different um, cultural ways of doing things or looking at things, and being non-judgmental and aware that um, other cultural beliefs and ways are or may be appropriate as well. So review in your book what these terms mean, and so make sure you have an understanding of what the differences are between these two. They're actually opposites. Factors related to women's health, or risk factors, I'm sorry, related to women's health. Social, cultural, and genetic influences are applicable to risk factors. Some are associated with ethnic groups and disadvantaged populations. When we look at nutrition factors that are associated with the risk factors, we're looking at things like eating disorders. You may have for example, an adolescent who may be underweight. She's not eating appropriately, or a lot of times they eat junk food that's full of empty calories. Um, or you may be looking at someone who is obese, which they may be getting a lot of calories, still empty calories nutritionally, but a lot of calories. Also, obesity leads to diabetes. So we're not only looking at obesity, but we're also looking at the diabetic risk factor that's associated with that. Substance abuse, illicit drugs can lead to miscarriage. Cocaine specifically will lead to placental abruption. SGA stands for small for gestational age. So drugs will lead to teeny tiny babies. Alcohol will lead to neurological disorders in the babies. Cigarettes, specifically the nicotine from the cigarettes, can lead to preventable death and illness in the babies, infertility, and what we call IUGR, which is fetal intrauterine growth restriction. So again, really small babies. Caffeine will lead to a miscarriage or a risk of miscarriage. So there are several factors that are risk factors for women's health and the health of the baby. Disparities in obstetrics. 38% of women are members of racial or ethnic groups. And in 2013, half of our births were to women of color. Disparities in health are likely among racial or minority groups. And a lot of that comes from inequalities in income and housing and education, and also related to jobs. Black American, Indian, and Alaska Native women are 2 to 3 times more likely to die from a pregnancy related causes when compared to white women. And these ratios increase with age and are affected more in women who are 30 or greater. The pregnancy-related mortality ratio for Black women with at least a college degree is 5.2 times that of their white counterparts. So even though we are looking at Black women who are college educated, they still have a much higher mortality rate. So that's taking us back to the genetic, the racial or ethnic component, which is a genetic component for the risk factor. There's some really nice research data in your textbook if you're interested in that, to go back and look at that research data that compares different racial groups. There's some other factors, which some of them can be related to the practitioner. If we're stereotyping or we have biases and patients are not getting the appropriate care. Ambiguity or medical information that's just not appropriate for the client. Either there's cultural things that are there or not included, or there's language barriers that were not being addressed. Biological factors and social factors, or maybe they're just getting late prenatal care. So those are several things that we could be looking at. Factors that may contribute to elevated cases of fatalities in Black women include some of these things that may directly affect mortality, and that is coexisting medical conditions, things like diabetes, hypertension, and obesity. And these are three that you want to review in your book this week as you are reading. These are three conditions that definitely increase your risk factors for poor pregnancy outcomes. Timing of entry into care, late prenatal care increases poor outcomes, and health systems factors. So access to care, the quality of care, and how consistent care is, all increase your likelihood of poor outcomes. In the US, we're ranked 30th in the world for maternal mortality rates. Worldwide, about 800 women die daily related to pregnancy and childbirth. That's a large number. Many of those deaths are preventable if they receive proper care. Preconception care and prenatal care is what we're considering proper care. A lot of those deaths are related to cardiovascular disease. And again, the comorbidities that are directly related to these mortality rates are hypertension, obesity, and diabetes. So anytime that we're looking at risk factors and maternal mortality, you have to always look at hypertension, obesity, and diabetes. Those are the three contributing factors. So make a note of that when you're studying, when you're reading. Go back and look at those three topics: hypertension, obesity, and diabetes. Okay, let's talk about assessment. And this goes back to your anatomy classes. Structures in the female reproductive system, you're going to find that on page 31 through 35 in your book. Puberty and when menses starts is on pages, or starts between ages 8 and 13. Menstruation and our pregnancy or our menstrual cycle prepares the uterus for pregnancy, and it begins, let's see how to say this. Ovulation starts 14, or how best to say it. The cycle starts 14 days after ovulation if a pregnancy doesn't occur. Regularity may be affected by age, physical and emotional status, and environment. So young people, young teenagers may be very irregular, Older women may be very irregular, and hormone imbalances may cause a lot of irregularity. Emotion affects regularity. If you have ever noticed that if something tragic is happening in life, something exciting is happening in life, you're getting ready to go on vacation and you're excited and stressed all at the same time, you may start your period. So emotional changes will affect the regularity of your period. So a lot of different things will change your regularity. Um, so look at menstrual cycle days in your book as you're reviewing for your exam. Preconception care is important. Prenatal care is important. Prenatal care should begin before 12 weeks. Most physicians start their prenatal visits at the 8-week mark. This is a view of the female reproductive system, and you'll find the ovary here on each side. These are called the fimbriae, little finger projections that come off of the fallopian tube that envelop the ovary itself. When the egg is released from the ovary, it is pulled into the fallopian tube, and you'll see the fallopian tubes here. The egg travels down the fallopian tube, and you absolutely do not want the egg to be implanted in the fallopian tube. It's fertilized in the fallopian tube, but you do not want it to implant there. You want it to travel on down the fallopian tube and implant in the endometrium. That's important. Here's your endometrium, the inner lining of the uterus. You want it to implant in the endometrium of the uterus. And ideally, it's going to implant high in the endometrium. We'll talk much later about what happens if it plants down closer to the, if it implants down closer to the cervix. That is not a good thing for the delivery process. So you want it to implant high in the uterus, in the endometrium. If a egg would be fertilized and implant in the fallopian tube, it cannot develop there. What would happen would be the fallopian tube would, as the cells divide and that cluster of cells enlarges, that fallopian tube would rupture. And the fallopian tube is very vascular. There would be a great deal of hemorrhage from that area. It would be an emergency surgery. Mom would likely lose that fallopian tube and could bleed to death if intervention was not pretty quick. So it can be a very serious situation. So you do not want implantation in the fallopian tube. You want implantation in the endometrium of the uterus. Couple things for you to review as you're studying. Review the menstrual cycle, how it is regulated by hormones. Look at the follicular phase, the luteal phase, and the role estrogen and progesterone, and that is really spelled wrong, progesterone plays in the menstrual cycle. Here is a sample of a wheel that we use, and it shows the follicular cycle and the luteal cycle. And when menstruation occurs, it's day 1 through 7. And then here, day 14 starts ovulation. So if someone is trying to get pregnant, menstruation is day 1 through 7. Then here is when you would have intercourse, hoping to get pregnant during ovulation time. So review this process in your book. As we're doing an assessment in a history and physical, you would want to assist with this process and want to do a complete H&P the interview process. You ask open-ended questions so the patient can elaborate on their answers. You want to develop a rapport with your patient so they trust you and will share information with you. We always screen our patients for abuse. Um, Pregnancy time is a time that women are at risk of being abused. So we want to keep that in mind. Um, we ask direct questions. We want to be very non-judgmental, placing no blame on individuals, making sure that they're comfortable to share information with us. We offer resources if needed. One thing that we want to be aware of is human trafficking. And I've done quite a lot of um, education with students and brought in people who are um, human trafficking educators. And one of the things that they always tell our students is that um, like 80 to 85% of people who have been trafficked have been seen in healthcare um, facilities, whether it's urgent cares or ERs. Um, they have been seen in facilities and never been given resources. Um, these people often come in with someone with them, and it doesn't always have to be a man. I mean, it can be a woman with them who is watching them to see what they say and um, not leaving the room. You know, we often ask for um, the person with them to leave the room briefly so we can ask the "Are you safe?" kind of questions. Um, and if they're being trafficked, a lot of times that person will not leave. So that's an indicator to us that something may not be quite right. We occasionally will have a partner that is overprotective, a mother that's overprotective, but most of the time we can tell them we have personal questions that we have to ask the patient alone, and it will just take a couple minutes and they can come right back in. Most of the time, um, family members are willing to step out for that. If you have a human trafficking situation and they will not step out, um, you can force it. Depends on how um, threatened you feel like that person is. If you're seeing visible signs that they may have been abused, you may need to have security ask someone to step out if you truly feel like they've been abused. Um, but what we often do is as we're showing them information, like maybe their discharge papers say they've come into an urgent care for treatment and maybe they have a UTI or something like that, and they come in for treatment. As we're giving them their discharge papers, we will provide them with human trafficking resource numbers and have it written down and point to it to where just the patient can see. And if you have, it will say things like, if you have questions or you need further assistance, you can call this number and point to it, point to the number where the patient can see, but the person with them cannot. So we're providing them with resources that the other person in the room cannot see, but we're still providing them with a resource when we let them go. And we're doing that because um, quite often these people who have been trafficked and said that they were seen in um, medical facilities and they were not offered um, resources, or maybe they were offered resources and they did not take them up on the offer, was because they had children that were in in the care or in the custody of their traffickers, and those children were being held as collateral. If they had told that they were being trafficked, their children would have been at risk. so they would never tell. But if we can get information into their hands to where if they find an opportunity that they can get out safely with their child, um, they may be able to get to a phone and use that contact information and get out with their children. So many of them have escaped with their children using resources that had been provided to them at a later date. So that's always something that you need to keep in mind if you have someone that you suspect is being trafficked. Intimate partner violence, again, during pregnancy is a very high risk time for intimate partner violence. And this is something that we need to be asking those questions. We need to ask them to step out as we're doing our questions. And, even if it's just briefly, and we need to ask the questions, are you safe at home? Have you been abused at home? Even if they say no and you're still suspecting something, again, give them resources. You would be surprised, the ones who actually admit to you that they are being abused or, do reach out for help. And we don't often ask the questions that we should be asking. The questions are built into our admission profiles on all of our electronic resources. We need to be asking these questions. I had a personal experience where my husband was out of town at a ball game. I had fallen, broken ribs, torn things in my shoulder. My parents took me to the emergency room. It was during COVID. I would not let them go into the ER because they're elderly. So I walked in to an ER with broken ribs, torn ligaments in my shoulder by myself, and not one person asked me if I had been abused. And I mean, this happened to be the facility that I worked in, but I didn't know anyone in the ER that night. Did not know anyone who was working. No one looked at me for old bruises. No one asked me if I was safe at home. No one asked if I had been abused. Nothing. It was the perfect scenario. So let's make sure that as healthcare providers that we are doing our job and asking those difficult questions. So do our health histories, make sure that they're accurate, that we're picking up things that may be significant and catching things early, because we want to make sure that we are not missing something. That when we talk about failure to recognize or act on early signs of distress, if we don't recognize early, that's failure to rescue, and we don't want to be guilty of that. We want to catch it when we're doing our health history and make sure that we recognize those things. Drug use. We want to make sure that we have a good, accurate history if we have a patient who has used drugs in the past or currently. Communication skills and cultural considerations. We've talked about our cultural considerations at great length. Washing our hands and gathering equipment. So as we're getting ready to do our physical exam, we want to make sure that we've washed our hands and that we've got all of our equipment ready. We have the patient empty their bladder and assist them into a lithotomy position. If they are early pregnancy, not a big issue, but if they are later in pregnancy, supine position with the weight of the baby on their back is going to cause hypotension. So we want to be watching for that. If they would say, oh, I'm getting lightheaded or dizzy, it's because of the weight of the baby on the aorta. So we would either like put our hand on the baby and push it over to the side a little bit, or help them put their legs down and help them rotate to the side a little bit to get the weight off of their back. Explain the procedure to them. This is important if we've got a young mom that this is the first time maybe. that they have had a vaginal exam. Um, it's not unusual for especially our teenage moms not to have been to a gynecologist before. And the first time they come in is when they're pregnant. So it may be the first time that they have had a vaginal exam. So be sure that you explain the procedure and what you're going to do and how it's going to feel. So we're going to do an external exam and an internal exam. Sometimes it's going to be the physician doing it. Sometimes it's going to be you as the nurse doing it. It just depends on the facility. So with that initial exam, we're going to do a pap test. We're going to do tests for sexually transmitted infections, gonorrhea, chlamydia, HPV, HSV, Group B strep. We'll talk more later about Group B strep. Group B strep is a normal flora if you're not pregnant. If you are pregnant, we take it much more seriously because if you deliver your baby with a positive Group B strep culture, the baby can become very sick. So if you have a positive Group B strep at this point in your pregnancy, we're going to treat you at delivery as if you were positive, even if you have a negative Group B strep culture late in pregnancy. And it's positive now, we're going to still treat you like you were positive, just because we know that you have the potential for Group B strep to be present. So we're going to treat as if you were positive, kind of once positive, always positive. And then we're going to review vaccines and screening. So, and just for an example, as we're reviewing your vaccines, if you were rubella non-immune, after you have the baby, we're going to offer you a rubella immunization. So MMRs are something that quite often we find that moms are non-immune to the rubella piece of the MMR. So we will offer that after delivery. Okay, what we're doing this week, we're reading chapters 1 through 3, doing our discussion question, which is our introduction, and completing the OB calculation piece 1. After you read chapters 1 through 3, go ahead and start reading ahead because next week there is a lot of reading. I think it's chapters like 6 through 10. So go ahead and get a jump start on your reading for next week. And next week is, go ahead and move forward. Next week, chapter 6 through 10. Next week is quiz 1. And quiz 1 will be questions, 7 of them from content from this week, 2 questions from content for next week. So content from chapters 6 through 10 and 1 math question. So if you struggle with your math, there are math resources available to you. So I would go in and look at your math resources and just practice some of those. There are probably 6, 7, 8 different math calculations that we use readily in maternity, in labor and delivery. And once you get those calculations down, you're going to be good for the entire term. So look at your math calculations on your resources and get those down early on, and you'll be fine for the rest of the term. Look at things like your for this time, look at your milliliters. Like if you're going to administer so many milliliters per hour and how many hours that it's going to infuse over, look at calculations for problems like that, and just make sure that you're comfortable doing those. Not any extensive drug calculations or anything like that yet. Just something very basic will be what you need to look at this week. So if you have questions, reach out to me. I will always be available to you. You have my contact information, and it was great to get to know you a little bit this week. I will be looking at your discussion questions. So I will feel like I get to know you a little bit better. Have a great first week and happy studying.